Imagine a vital organ right at the absolute crossroads of your bodily plumbing that doctors historically had to operate on while, effectively flying blind.
Yeah, it was basically a medical guessing game for a really long time.
Right. I mean, we're talking about an organ that's roughly the shape of an upside-down cone, tucked deep inside the pelvis, sandwiched right between the bladder, the rectum, and the pelvic floor.
Prime real estate, but terrible for visibility.
Exactly. For decades, treating this organ, the prostate, obviously involved a massive amount of guesswork. If something went wrong, finding out exactly what and exactly where was, well, incredibly difficult.
It was. But today, we are taking a deep dive into a fascinating 2025 medical review called Anatomy of the Prostate and Periprostatic Region. And, the historical contrast is really what makes this review so important.
Because we aren't guessing in the dark anymore.
Exactly. We are absolutely no longer making educated guesses. The evolution of high-resolution MRI has, completely revolutionized our understanding of this space.
It's like turning on the lights in a dark room.
Better than that. It's not just about noticing, oh, there's a disease here like cancer or an enlarged prostate. It's about mapping the biological terrain with such precision that surgeons can now navigate it like a turn-by-turn GPS.
So reading a modern MRI of the prostate is less like looking at a static photograph and much more like reading an incredibly complex three-dimensional topological map.
That's a great way to put it.
And the goal of this deep dive is to decode that map for you. We're going to explore how doctors use this imaging to preserve a patient's quality of life, which, is more important than ever right now.
It is, because the stakes are incredibly high. Patients are being diagnosed with prostate issues at younger and younger ages.
Right, which changes the math on treatment.
Entirely. When you're dealing with a younger patient, the balance between curing a disease and preserving their vital day-to-day functions, specifically, urinary continence and sexual health, is absolutely critical.
You can't just go in with a sledgehammer.
No, definitely not. To achieve that delicate balance without making compromises, doctors must understand exactly, down to the millimeter, what they're looking at on those scans.
Okay, so before we can understand how things go wrong in the prostate, we really have to understand how it's built, right? And more importantly, why it's built that way.
Form follows function.
Exactly. So the review starts with the physical geography. It sits in what's called the subperitoneal compartment. So if you imagine a deep bowl formed by your hip bones, the prostate is located deep down in that bowl.
Way down there.
Yes, sitting beneath the abdominal cavity, tucked directly behind the pubic bone in the front and resting just in front of the rectum in the back. But what is this gland actually doing down there to require such complex real estate?
Well, to understand the geography, you really have to understand the function. The prostate is essentially a manufacturing plant and a pumping station.
Two totally different jobs.
Right. Its primary biological job is to produce a significant portion of the fluid that makes up semen, which nourishes and protects sperm. That's the manufacturing part.
Okay.
And then, during ejaculation, its muscular components forcefully contract to pump that fluid out through the urethra.
So it's the pump.
Exactly. And because it has these two different jobs, making fluid and pumping fluid, it's made of completely different types of tissue.
So how do the radiologists who read these MRIs actually map that out? Because the sources mention that doctors treating the exact same organ don't always, use the same map.
They don't. And that has been a long-standing issue. Radiologists rely on a system called McNeil's zonal anatomy.
Zonal anatomy, okay.
Yeah, it's the official language of modern MRI and how radiologists grade suspicious lesions. It divides the prostate into distinct zones based on exactly what kind of tissue we are looking at.
So it's based on the actual biology of the tissue.
Right. So first you have the peripheral zone. This makes up the vast majority of the gland, mostly wrapping around the back and the side.
And this is the manufacturing plant, right?
Yeah, exactly. It is highly glandular, meaning it's packed with the cells that manufacture that fluid. And because it has so many active dividing glandular cells, this zone is the hotspot where the vast majority of prostate cancers develop.
Okay, so the peripheral zone is the main manufacturing floor, prone to cancer. What are the other zones?
Next is the transition zone. This is a much smaller glandular area, and its defining feature is that it wraps directly around the urethra.
The tube that carries urine out of the bladder.
Exactly. Now, while the transition zone doesn't get cancer nearly as often, it is highly prone to swelling and enlarging as men age.
Which we'll definitely get into later.
Oh, for sure. Then there's the central zone, which is a cone-shaped wedge of tissue near the top that surrounds the ejaculatory ducts.
Got it.
And finally, you have the anterior fibromuscular stroma.
That sounds intense.
It's a mouthful. But it covers the entire front of the prostate. It's technically not even a zone because it contains zero glandular tissue.
Wait, no glands at all?
None. It is just a thick band of dense connective tissue and smooth muscle. Because there are no fluid-producing glands here, it physically cannot develop prostate cancer.
Oh, wow. So it's just pure muscle.
Right. Its only job is to contract and act as that pump we talked about earlier.
Wait, okay. So if the radiologist is using these incredibly specific, biological zones, what map are the urologists, the actual surgeons, using when they go in to operate?
Well, historically, urologists have used a completely different system called lobar anatomy.
Lobes instead of zones.
Exactly. Instead of zones based on tissue type, they break the prostate down purely by its physical shape. So you have a right lateral lobe, a left lateral lobe, and a median lobe.
And that median lobe is the one right in the middle, right?
Yeah, and it can actually grow upward, protruding straight into the floor of the bladder.
Okay, let me make sure I'm following this. It sounds like looking at a house.
Okay, like that.
So the radiologist, using the zones, is acting like the structural engineer. They are looking at the foundation, the plumbing, and the load-bearing walls.
Right.
Meanwhile, the surgeon, using the lobes, is acting like the interior designer. They are just looking at how the rooms are divided and how the doors open. Are they really using entirely different blueprints for the exact same surgery?
Yes, they are. And that is exactly why this review was published. It highlights a very real communication gap.
I can imagine.
I mean, when a radiologist finds a tumor in the, say, anterior horn of the peripheral zone, the urologist needs to know exactly how that translates to their physical, surgical approach.
Otherwise, they're looking in the wrong room.
Exactly. So this paper actively discourages doctors from using vague, older terms because it causes clinical confusion. The goal is to get everyone speaking the same highly precise anatomical language.
Which makes total sense. Now, knowing the rooms inside is one thing, but knowing where the property line ends is where the real danger lies.
Absolutely.
Because crossing the border of the prostate changes absolutely everything. But the sources reveal this wild anatomical plot twist here. The prostate doesn't actually have a true wall around it.
Yeah, that surprises a lot of people. If you look at a kidney or a liver, they are wrapped in a neat, tough, solid envelope. It's called a true histopathologic capsule.
Like a skin, almost.
Right. But the prostate doesn't have that. It has what we call a pseudocapsule.
A fake capsule.
Pretty much. It's really just an incredibly thin layer of fibromuscular tissue that forms exactly at the boundary where the prostate meets the surrounding pelvic fat.
Okay, and inside the gland.
Inside, there's another invisible border called the surgical capsule. And again, this isn't a capsule either. It's just a band of naturally compressed tissue, separating that inner transition zone from the outer peripheral zone.
But wait, if there is no actual solid wall, like no physical barrier holding this organ together, how does a surgeon know when to stop cutting?
That is the million-dollar question.
Because right outside this phantom border is some incredibly vital biology, right?
Oh, it is intensely prime real estate.
Yeah.
Right next door, you have the internal and external urethral sphincters.
Which you need to hold your urine.
Exactly. Those tiny circular muscles are non-negotiable if you want to maintain urinary continence. And then you have the seminal vesicles. And perhaps most critically, you have the neurovascular bundles.
Yeah, NBBs.
Right. These are complex, microscopic networks of nerves, veins, and arteries that control a patient's erectile function. They sit layered between these delicate sheets of fascia, forming a sort of fragile cage around the back and sides of the prostate.
So a surgeon is working literally millimeters away from nerves that control a patient's entire quality of life, and there's no protective wall to guide them. That is terrifying.
It is, and this is the core reason MRI is an absolute game changer. An MRI magnet is basically looking at how water molecules behave inside the body.
Okay, tracking the water.
Yeah. In the glandular tissue or the surrounding fat, water molecules have room to move around. But in that dense, fibrous pseudocapsule, the water is tightly restricted.
It's packed in tight.
Exactly. So on a specific type of scan called a T2-weighted MRI, that restriction of water creates a very distinct dark line. We call it a T2 hypointense band.
So it draws the line for you.
Yes. The MRI visualizes a border that is almost invisible to the naked eye. This allows surgeons to precisely map out nerve-sparing surgeries before they even make an incision. They can literally see if there's a safe margin to peel those vital nerves away unharmed.
Because that border is effectively invisible otherwise. And, when cancer grows, usually in that glandular peripheral zone we talked about earlier, knowing exactly where the tumor touches, that dark line dictates the entire treatment, right?
Oh, absolutely. If the tumor stays safely inside the gland, the prognosis is one thing. But radiologists are constantly hunting for a microscopic breach. We call it extraprostatic extension.
Extraprostatic extension, or EP.
Right, EPE. This occurs when the tumor bulges into or just outright breaks through that fragile pseudocapsule and starts leaking into the surrounding periprostatic fat.
Oh, so it's escaping the property line.
Exactly. The moment a radiologist spots that dark line being interrupted, the entire staging of the cancer shifts. It means the cancer is attempting to escape. The prognosis worsens, the urgency increases, and the treatment plan has to become much more aggressive.
And the sources mention seminal vesicle invasion, too.
Yes, same alarm bells ring there. That's when the tumor creeps up the ejaculatory ducts and physically invades the walls of the seminal vesicles.
So how does that actually change the treatment? Like, let's say a patient undergoes a radical prostatectomy, which is the surgical removal of the whole gland.
Well, if the cancer is escaping, the surgeon's job becomes incredibly difficult. Their goal is to get negative margins.
Which means?
It means they remove the whole prostate, plus a thin rim of completely healthy tissue around it, ensuring no microscopic cancer cells are left behind in the body.
Got it.
But because the space in the deep pelvis is so tight and surrounded by bone, getting clean margins at the very top of the prostate, or the very bottom at the apex, is notoriously tricky.
Because if they cut too wide,
They sever the sphincter and cause permanent incontinence.
and if they cut too close.
They leave cancer behind.
Man. Which is why some patients require radiation therapy instead of surgery. But radiating the prostate seems just as complicated because, well, the rectum is sitting right there.
Literally millimeters away.
Right. If you blast the prostate with radiation, doesn't the rectal wall take severe collateral damage?
Historically, yes. That was a massive problem, leading to severe toxicity and really painful side effects. But the review outlines this fascinating surgical hack.
The spacing devices?
Yes. Doctors can now use spacing devices. They're these hydrogels with brand names like Space OAR or Berigo. Before radiation begins, a doctor uses an ultrasound to guide a needle into the microscopic space between the prostate and the rectum, and they inject the specialized gel.
And just puffs up?
Exactly. It physically inflates, creating about a centimeter of artificial space. It pushes the rectum away and completely out of the radiation field.
So, using a spacer is literally like sliding a fire blanket between two houses right before you set fire to a wasp's nest inside one of them.
I love that analogy. Yes, and that physical distance is the absolute best protection you can get against radiation scatter.
But I'm guessing placement is key.
Oh, perfectly. It has to be perfect.
Yeah.
If you deploy that fire blanket inside the siding of the neighbor's house, you cause structural damage.
Oh, geez.
Yeah. So after the gel's injected, they run an MRI to ensure there is no rectal wall infiltration. They have to verify the gel expanded in the empty space and didn't accidentally inject into the muscle fibers of the rectum itself.
That level of precision is wild. And it's also true for focal therapy.
Completely.
Yeah.
Focal therapy is this newer approach where instead of removing or radiating the whole gland, they just target the specific tumor.
Like a sniper approach.
Exactly. They might freeze it with cryotherapy or use high-intensity focused ultrasound to literally cook the cancer cells while leaving the rest of the prostate completely intact.
But the mapping has to be flawless.
Right. To pull that off safely, the MRI has to map the tumor's exact coordinates. Knowing the precise relationship of the tumor to that external urethral sphincter down to the millimeter is quite literally the difference between a total cure and a patient suffering from lifelong incontinence.
Okay, so we've talked a lot about cancer, but cancer isn't the only way this real estate gets compromised. Sometimes the organ just grows too big from the inside, turning a perfectly functioning system into a backed-up plumbing nightmare.
Yes, the plumbing issues.
This brings us to benign prostatic hyperplasia, or BPH.
BPH is an incredibly common non-cancerous condition as men age. Remember that transition zone, the area that wraps directly around the urethra?
The one right in the middle.
Right. Over time, the tissue there begins to hypertrophy, meaning it overgrows. It forms these dense, benign nodules.
And because we know the anatomy now, we can see why this causes such a brutal mechanical cascade.
Exactly.
I mean, the prostate is constrained on the outside by that pseudocapsule and the pelvic bones. So as those transition zone nodules grow, they can't really expand outward.
No, they have nowhere to go.
So they expand inward. They literally start crushing the urethra shut.
That's exactly what happens. The internal surgical capsule hypertrophies as well. It begins to act like a tight corset, transmitting all of that outward growth back inward, putting direct pressure onto the urine channel.
And it doesn't just go inward, right? Sometimes it goes straight up.
Yes. If that median lobe we mentioned earlier overgrows, it can protrude directly up into the floor of the bladder like a mushroom.
Like it's punching into the ceiling.
Pretty much. It physically distorts the anatomy of the bladder itself, and in severe cases, it can even block the tiny tubes bringing urine down from the kidneys. It's a severe mechanical obstruction, and it requires a mechanical fix.
So how does a surgeon actually fix a blockage like that?
Well, there are a few ways. Historically, the gold standard is TRP transurethral resection of the prostate.
Okay.
A surgeon goes in through the urethra and essentially shaves away pieces of the overgrown tissue to widen the channel.
Just scraping it out.
Basically.
Hmm.
But newer methods have evolved for larger prostates, like holmium laser enucleation of the prostate.
Lasers.
Yes. Here, the surgeon uses a laser to find that surgical capsule boundary. Imagine peeling an orange from the inside out. They completely core out the entire overgrown transition zone in one large piece, push that tissue up into the bladder to get it out of the way, and then use a device called a morcellator to shred it and suck it out.
Wow. Okay, and what about smaller prostates?
For smaller prostates, there's a less invasive option called the urolift. Instead of cutting or lasering tissue away, they deploy tiny stainless steel and nitinol anchors through the urethra.
Anchors?
Yeah, these anchors physically pin the obstructing lobes back, just permanently holding the channel open.
Okay, so if the urethra is a narrow hallway, BPH is the walls slowly closing in on you.
Right.
2RP is basically chipping away at the drywall. HOLEP is gutting the room entirely back to the studs, and Urolift is just using heavy-duty thumbtacks to pin the heavy curtains back to the walls.
Yes. And actually, taking that Urolift thumbtack analogy a step further, leaving those literal metal anchors in the walls creates a massive headache for radiologists later on.
Wait, really? Why?
Because Urolift leaves permanent metal in the body, which causes what we call susceptibility artifacts on future MRIs.
Oh, the magnets freak out.
Exactly. The magnetic field of the MRI scanner physically distorts around the metal. It literally blacks out or smudges up to a third of the transition zone on certain critical scans.
So solving a plumbing problem today with metal anchors might severely blind your cancer radar tomorrow?
It's a very real trade-off that patients and doctors have to consider.
That is a wild medical trade-off. But metal anchors aren't the only things that can blind an MRI or confuse a radiologist.
Not at all.
Sometimes the prostate itself throws up biological smoke screens. We've looked at cancer and BPH, but MRI readers also have to play detective. The prostate is full of decoys.
Yes, the great mimics.
Right. Things that look exactly like worst-case scenarios on a scan, but are actually something else entirely.
And this is where clinical context becomes everything. One of the primary mimics is infection.
Like a bacterial thing.
Yeah. If a patient gets acute bacterial prostatitis, often caused by common bugs like E. coli, it will show up on an MRI as a dark focal spot that restricts water diffusion.
Which looks exactly like cancer.
It looks incredibly suspicious.
Yeah.
And if that infection is left untreated, it can consolidate into a prostatic abscess, a thick-walled, fluid-filled pocket of pus that might actually require a surgeon to go in and pop it open to let it drain.
Ouch. But, okay, the most mind-blowing mimic mentioned in the sources is granulomatous prostatitis.
Oh, yes.
This is a specific type of inflammation that looks exactly like clinically significant prostate cancer on an MRI. But the cause is what shocked me. It can happen after a patient receives BCG immunotherapy, well, for bladder cancer.
True.
Wait, hold on. If you're treating my bladder cancer, why are you injecting something that ruins my prostate MRI? How is that an acceptable medical trade-off?
I know, it sounds like a terrible trade-off. And it's a diagnostic nightmare for radiologists.
Okay.
But you have to look at the biology of the treatment.
Okay, break it down.
The BCG vaccine is an immunotherapy instilled into the bladder to provoke a massive immune response that kills off superficial bladder cancer cells. And it is highly effective.
Okay, good for the bladder.
Right. But because the prostate is directly attached to the base of the bladder, that intense inflammatory response often spills over. The immune system causes these dense inflammatory lesions in the prostate itself.
So on the scan, it looks terrifying. The MRI shows a dark spot restricting water diffusion, which is the classic hallmark of dense, aggressive cancer cells.
Precisely. But this is why we say we treat the patient, not just the picture.
Context is everything.
Exactly. If the radiologist has the patient's history and knows they recently underwent BCG therapy for bladder cancer, they can connect the dots. A simple biopsy confirms it's just inflammation from the immunotherapy, saving the patient from a massive, completely unnecessary cancer surgery.
Wow. The review also touches on cysts, right? Which are little fluid-filled sacs that can pop up and mimic tumors or abscesses.
Yeah, they do happen.
And they actually have their own specific geography. You have utricle cysts, which are pear-shaped and sit right in the midline, communicating directly with the urethra.
Yep.
And then you have Mullerian duct cysts, which are teardrop-shaped and reach up above the prostate entirely.
And while they sound alarming, they're usually entirely harmless.
Just little water balloons.
Pretty much.
Yeah.
But knowing those subtle shape differences, pear versus teardrop, and their exact location relative to the internal plumbing allows the radiologist to confidently tell the patient, it's just a cyst, it's not a tumor.
That's a relief.
Right.
All
They
right.
really become an issue if they grow large enough to cause pain or block the plumbing and cause infertility.
Well, so let's bring this all together. We started with a simple upside-down cone tucked deep in the pelvis. We explored its complex function as a fluid manufacturer and a pump.
The two jobs.
Right. We mapped out the confusing zones and lobes, found its invisible phantom boundaries, and explored how high-resolution MRI is acting as a surgical GPS.
It really is a GPS now.
Guiding everything from laser enucleations that gut the inner rooms to injecting fire blanket gels to save the vital nerves hugging its surface.
And we also uncovered how the prostate can trick us, throwing up biological decoys like inflammatory lesions and cysts that require a true detective's eye to untangle.
Exactly. And, understanding this anatomy isn't just for medical students or radiologists. If you or a loved one ever face a prostate issue, knowing this landscape empowers you.
It absolutely does.
Knowing the difference between the glandular transition zone and the peripheral zone, understanding what an MRI is actually looking at, or knowing to ask your doctor about nerve-sparing techniques and radiation spacers, that knowledge puts you in the driver's seat in the doctor's office.
It completely shifts the dynamic from simply sitting there and receiving a diagnosis to actively participating in a highly precise, personalized treatment plan.
And I want to leave you with a final, somewhat mind-bending concept to ponder. We talked about focal therapy earlier.
Right. Targeting just the tumor.
Yeah, using lasers or extreme cold to destroy just a tumor rather than the whole gland. As our MRI imaging gets closer and closer to the microscopic level, and our robotic interventions become as precise as a pinpoint laser beam, will we eventually stop viewing the prostate as a single, unified organ that gets sick?
It's an interesting thought.
Right. Like if we can map every single millimeter, could we start treating the prostate not as one upside-down cone, but as a collection of hyperspecific, independent microenvironments? Could the days of treating the whole gland for anything soon be entirely a thing of the past?
It's an incredible thought. When our map of the body becomes as detailed as the territory itself, the way we wage war on disease changes forever.
Something to think about next time you look at a medical scan. It's not just a picture, it's a living, breathing landscape. Until next time, keep exploring.